Welcome to ATCM, the Emergency Medicine Channel. Today I will be presenting a case of a 62 years old male who presented to our ear with complaints of melena since 4 days, abdominal pain since 5 days, fever with cough since 3 days and fatigue since 1 week. On our 10-second initial assessment, airway was patent, no pooling of secretions or gurgling sounds. Breathing bilaterally equal, chest movements, air entry bilaterally equal, no added sounds. Saturation was maintaining at 99% on room air, respiratory rate of 18 per minute. Circulation, heart rate of 73 beats per minute regular, BP of 140/80 millimeters of mercury. Disability, GCS of 15 out of 15, E4, V5, M6 and pupils equal and reacting to light. Moving all 4 limbs. Exposure, GRBS of 210 and temperature of 98. Adjuncts of primary survey, we took a VBG which showed no acid-base imbalance and the HB point of care was shown as 6.9. ECG was showing normal sinus rhythm. At this point of time, 2 18-gauge IV cannulas was inserted and we had arranged for 2 pint PRBC and we have sent all the labs. Secondary survey, the patient 62-year-old male, known case of hypertension, BPH, was having fatigue lethargy since 1 week. After 3 days, he noticed black tarry stools and the next day he also had a central abdominal pain, more towards the epigastrium, with no radiation. It improves after taking meals. He is also complains of a history of high-grade fever with chills and rigors, with continuous in nature, with cough with white sputum. He does not complain of any hematemesis, abdominal distension, constipation, altered sensorium, altered sleep cycle, chest pain, shortness of breath, no history of any allergy, no history of any audinophagia, dysphagia, or no history of any other drug intake. No history of allergy to medications. Coming to medication history, he is on Nebicard 5 mg, losartan 25 mg, silodosin 8 mg, and he has given a history of taking Ayurvedic medications since 1 month for the abdominal pain. Past history, he has hypertension and benign prostatic hypertrophy. Last meal was taken 6 hours back. On examination, patient
we will wait here. Can you just summarize once more the key findings till now? So basically you have an elderly gentleman with history of melena for 5 days and also some associated short febrile illness. Generally he was hemodynamically stable, vitals were stable. Right? Yes. And no other significant examination findings. ABG was showing a hemoglobin of 6.9. There was not even tachycardia, right?
Like no tachycardia was 73 beats per minute.
Okay, and no other significant findings, right? This is where we are at this point. Okay, yes. So in the history, what significant negative history you have to tell, like other than whatever you have told? What are the specific drugs? What are the specific drugs which you are looking forward in an upper GI bleed?
In upper GI bleed, we have to take history of any NSAIDs intake or use of any SSRIs.
So basic, most important thing is antiplatelets and anticoagulants. Okay, then the other things including spironolactone, SSRIs, NSAIDs will come. Okay, fine. Then what can be a mimic of black tarry stools?
Taking iron
tablets or
yeah, here both Ayurvedic will also contain some kind of heavy metals and things like that. No? So basically Ayurvedic medications, again, if it has a temporal correlation, like it was started and from next day he is having, then that needs some weightage in history. And other than that, as he told, your iron tablets. Okay, then or any iron preparation for that matter. Okay, then so that was with the history part. Okay, and from a history perspective, any other diseases in upper GI bleed or melena?
Any other diseases? No.
No. What things CLD, you should be looking at? Yeah, exactly. Here we don't have.
No.
So that again becomes important. No. Okay. Anything else? Any past episodes of similar events?
First time. But he has had recurrent abdominal pains, upper abdominal pain, heartburns and all previously.
Okay. Fine. So these are the relevant histories which you have to definitely ask. Okay. But as of now, it looks like a stable kind of a bleed. Okay. So in cases where, so here we have a clear-cut, overt kind of a bleeding, no?
Yeah.
Okay. If there is an occult bleeding, how will you approach for anemia?
Full bleeding.
What will be like? Definitely, you'll need to send for a stool occult blood. No. So why I went to that is there can be certain mimics. Okay. What can be the situations where you can get a false SOB positivity, where it need not be a GI bleed. So one thing is definitely other than the GI tract itself, an epistaxis, okay, and any other thing in the upper airway itself can mimic. And there can be other food materials and even red meat. Okay, those kind of things can give a false positivity in SOB. So those kind of things also you need to be aware of. Okay, so that is with the initial complaint. Fine, proceed.
On examination, the patient was conscious oriented, pallor was present, no icterus clubbing, cyanosis, lymphadenopathy or pedal edema. Coming to systemic examination, GIT, it was soft, non-tender, no guarding or rigidity, no shifting dullness or organomegaly, bowel sounds were present. Rest of the systemic examination was within normal limits.
Okay.
Differential diagnosis we arrived at was peptic ulcer or a variceal hemorrhage or
no, at this point you can be as big as upper GI bleed. No, it could be anything. We don't have anything to suggest a variceal etiology. He's not a CLD or anything. Okay.
No, not
so
known
it
case.
Can be very high possibility of upper GI bleed. That's all we can say at this point. Okay. Why do you say upper GI bleed and not lower GI bleed? So how do you differentiate?
Lower GI bleed will present with hematochezia, with fresh red blood in stools, and that's the main differentiating history. Then in upper GI bleed also we might have hematemesis. If it is severe bleeding, patient will have hematemesis or vomiting of clots be present.
Okay. So what is the anatomical structure which is going to differentiate between upper and lower?
Above ligament of Treitz.
Above ligament of Treitz is what is usually classically called as upper GI bleed.
Upper GI bleed. Then coming to investigations, we sent all the routines and USG abdomen was done to rule out CLD, and the labs came out as HbS 6.87.
Okay.
Rest of the lab results were normal. USG abdomen also showed no evidence of any CLD, only grade 2 fatty liver was present.
Okay.
We planned for we informed the gastromedicine department and we planned for a OGD-scopy.
Okay.
And then we also transfused 1 pint PRBC at the same time because the SB was less than 7. 1 pint PRBC transfusion was done.
Okay. So what are the usual indications for HP transfusion in upper GI bleed?
In upper GI bleed, we can transfuse if the SB is less than 7.
In all cases, or is there a difference in transfusion threshold depending upon anything else?
Based on if the patient has underlying cardiac failure. CAD patients.
So the thing is that it's again more than 9. Okay, you keep a threshold of 9. So if it is less than 9 hemoglobin, you transfuse in and CAD. Especially when there is a recent history of MI and all, definitely you have to transfuse. The other thing is that you have an overt, you are suspecting a very rapid kind of a fall. Hemoglobin, like morning it was like 12, now it is 10. Those kind of situations also where you are anticipating a heavy arterial ooze or things like that also, you are justified in going for a. The third indication for a higher threshold will be in hemodynamic instability or this high bleeding will be if the patient is having coagulopathy. Again, okay, fine. So here you have planned to transfuse 1 and you can arrange for 1 more pint of PRBC.
Right. Then we planned for endoscopy. In that it was done within 12 hours itself. In that we found out a duodenal ulcer which was oozing. And there and there they itself they kept a hemoclip over there.
Okay, so fine. So here you have planned for an endoscopy. Yes. How will you decide on the timing of the endoscopy? Like is endoscopy indicated like emergently in all kind of patients, or?
If the emergency indication is there, if there is a hemodynamic instability or active bleeding indications as in continuous hematemesis.
So here it is kind of a semi-elective kind of procedure. So is there any drugs which probably will help in?
We started on a PPI also, pantoprazole 80 mg with
We'll come to
infusion.
that. No. Any drug which can aid in visualization in endoscopy.
Yeah, we can give a metoclopramide
Okay.
to clean the particulate material.
So these will be the subgroup of patients where probably metoclopramide and things like that will help, because endoscopy, we are not rushing into an endoscopy. Usually the onset of time is between half an hour to 2 hours. Okay, so prokinetics definitely has a role in such kind of patients. Okay, then. Okay, in this case scenario, it is going like a very simple kind of a case. We'll complicate it in due course of discussion. Continue.
We had given injection metoclopramide and also injection pantoprazole was given.
How much?
First 40 mg was given and then continuous infusion was going on.
So the recommended dose in a suspected ulcer bleed will be 80 mg of
80
pantoprazole
mg
stat followed by 8 mg per
8
hour.
mg per hour.
Till how much duration you are going to continue pantoprazole?
For up to.
Evan, want to come in? Okay, so basically your duration of pantoprazole will depend upon the endoscopic finding. Okay, if you are having a high risk stigmata of bleeding, then definitely the longest duration is for 72 hours. Okay, or else if it is not there, you can make it BD upfront. And there are now studies which prove that almost infusion and BD dosage is almost equally efficacious. So any patient, if somebody is writing 40 mg BD, then it can be justified. Okay, and in due course you can convert to IV to oral. Fine. And any other drug other than pantoprazole? Omeprazole again,
yes,
there is enough evidence to attempt that. Fine. So you gave PPI, then?
PPI and prokinetics were given mainly.
Okay. So of course, pre-endoscopy you can start on these two things. Then continue.
We kept the patient NP also.
Okay, good.
And we started on prophylactic antibiotics as well.
Not usually indicated. If the patient is not CLD, no, just for upper GI bleed, there is no indication for antibiotics. Okay. Then that's it. Okay. We'll go through the basic causes and all. Okay. So what are the etiologically? We'll just discuss upper GI bleed then. So from etiology point of view, what are the causes of upper GI bleed? Why will you broadly classified?
It can be classified into peptic ulcer. It can be one cause.
The broad classification is varicose and non-varicose.
Varicose,
So it is under non-varicose that you will get all these things. Okay. So let us take non-varicose. So what are the things in non-varicose?
Peptic ulcer can be there.
Good.
Esophageal ulcer, malarial stare,
Okay, good.
AV malformation, or angiodysplasias.
Good.
Then any long-standing and all carcinoma we can suspect.
Okay. And ectasias, erosions, esophageal erosions. Okay. So that is with the non-varicose. And varicose is classical in CLD.
CLD.
You have both esophageal and gastric varices. Fine. Then, so that is with the etiology point of view. Risk factors, we quickly discussed about the drugs. Okay, whatever drugs can cause. Other risk factors include your CLD and other etiologies which can lead to varicose bleed. Fine. Then, clinical examination. Again, if CLD is there, a stigmata of liver disease and things like that needs to be looked into. Any other examination findings?
Postural hypertension you have to check.
Okay. Then depending upon other rarities and all, specific findings you might go, that's okay. Then, so that's with the clinical examination. And evaluation, investigations?
Investigations, you have to send routines for the hemoglobin level, then for the blood urine nitrogen, creatinine, we can check the blood urine nitrogen creatinine ratio or a urea creatinine ratio. It will be raised mostly in GI bleed, upper GI bleed.
But that information is not going to help us much in management per se. It is more of an incidental kind of thing, no? Okay, so hemoglobin, CBC with hemoglobin is definitely yes. Then
platelet levels.
Okay, more than that?
INR.
Good. Coagulation profile is
Coagulation profile.
fine.
Has to be.
Then
Liver function test.
okay, good. So blood test that much. Okay. Then after that?
Then we can do ultrasound.
Again CLD
to rule out the
features.
CLD.
Okay.
Then we have to plan for endoscopy.
Okay. Fine. So now here we had a patient who is very, very stable. So let us say the patient comes in a very unstable kind of a situation. Okay. You have a patient who is rushed in, who is actively having hematemesis. let us handle such a scenario. What are the specific things you are going to handle as an ER physician?
First, you have to check for the airway.
Mm-hmm.
If it is compromised, you have to do a intubation.
Mm-hmm.
And also we have to keep the patient NPO.
Mm-hmm.
Then we have to start on IV fluids.
Mm-hmm.
And we have to check for HB, point of care,
Mm-hmm.
and arrange for PRBC.
Mm-hmm.
If there is active bleeding, if we require more amount of PRBC, we have to also arrange for the plasma and platelets as well to prevent dilution coagulopathy.
Mm-hmm.
Then
Eben, want to add anything? If you are suspecting varices. Okay.
First, we need to look at the vitals. Actually, vitals itself will say whether the patient is in which stage of shock itself. If the patient is in just tachycardia, then it comes to class 1. When it comes to hypertension, then we need to immediately put 2 large for IV cannulas. And blood is the main management, but by the meantime, we can push the patient with fluids. And since you said like that, if there is multiple episodes of hematemesis, we need to look at the airway compromises there. So we need to anticipate an aspiration, but initially the vitals has to be stabilized, and then we have to go ahead with other management.
One key thing both of you missed is that the position of the patient. Okay, always keep the patient with an ongoing bleed with dropped position at 45 degrees. And moreover, again here the fluids. Okay, the initial thing was always rushing fluids. Now there is reasonable evidence to state that there is no point in overloading the patient. Okay, whatever you are going to give is just causing further hemodilution and it's continued to bleed. Okay, so some amount of permissive hypotension is acceptable as long as sensorium is preserved, and you can earlier start on inotropes itself rather than giving too much of fluid. Okay, initial bolus fine. If you are feeling that there is ongoing bleeding, then directly upfront you can maintain a lower map with a small dose of inotropes. That is justified. Okay, that is with the circulation part. Coming to airway, is there any specific methods which can help in securing the airway in an ongoing bleed? What is salad approach? Suction assisted laryngoscopic airway decontamination. So basically what we are doing is that usually the head is up at 45 degrees. You do a laryngoscopy. Along with that, you introduce a suction. Usually your younger suction or a mucus extractor we use usually. So you place a younger suction on the side, you clear the airway, decontaminate it. After that, with that in situ, with the suction ongoing, we will go ahead and intubate the patient. Okay, so that is called as the salad approach. Regarding drugs, anything specific?
We can give ketamine suspecting because.
Yeah, ketamine will be a reasonably good choice in situations like this. Okay, and again, make sure that you don't cause further hypotension during intubation. Okay, always stabilize the patient as much as possible before you go ahead and intubate. Again, there may be situations where we might need to intubate the patient to aid endoscopy. So you have an ongoing bleeding. GCS may not be that bad, but just for aiding the endoscopy also, you might need to secure the airway. Okay, in those kind of situations also, make sure that the BP is maintained while you intubate the patient. Okay, now we have an unstable patient, we have intubated the patient, we have reasonably maintained the BP all throughout, and we are going ahead with the endoscopy. So what are the endoscopic classification in ulcers?
We have Forest classification.
Okay.
In which class 1A is the spurting, class 1B is oozing, class
Arterial. It is arterial spurt.
Yeah, arterial spurt. Class 1B is oozing, and class 2A is non-bleeding visible vessel. Class 2B is adherent clot. Class 2C is flat pigmented spot, and class 3 is clean ulcer base.
Okay.
In classes 1A to 2A, there will be a chance of recurrent bleeding be present.
Okay. So is there any score which can kind of predict the need for scopy?
Yeah, we can use the clinical scoring Glasgow Blatchford score.
Okay. How is it?
In that, the scoring from 0 to 23. We can check for the blood urine nitrogen, hemoglobin, the systolic blood pressure, pulse, melena, presence of melena, syncope, or presence of hepatic disease or cardiac failure.
Okay.
Based on that, we'll score from 0 to 23.
Okay.
If it is 0 to 1, we can wait and watch. Otherwise, we have to, with the increasing scores, we will have to plan for endoscopy and further treatment.
Okay, fine. Right. Anything else you want to add?
Coming to the signs, we can assess the percent of blood loss. Like less than 15% blood volume is lost, we can the patient will be having resting tachycardia. If there is 15 to 40% blood loss, the patient will be having orthostatic hypotension. If it is greater than 40% in supine, also he will be having hypotension. Then we also have to rule out perforation by checking for rebound tenderness or guarding or rigidity.
Okay. Is trials tube indicated in upper GI bleed?
With current guidelines, it's not routinely indicated. But if you want to, if you suspect any,
No. So the answer would be in a tertiary kind of a center where endoscopy is available, there is zero rule. Okay. So there is no point of using a Ryle's tube to diagnose or decontaminate or empty the stomach. Okay. In probably in peripheral kind of centers where the diagnosis is in dilemma, definitely there might be some questionable rule. But again, is there any situation in an upper GI bleed where Ryle's tube is contraindicated? Again, that is kind of a misconception. So basically, just absence or presence of a varices does not rule out. Patient who has undergone an EVL, endoscopic ligation, definitely that will be one subgroup of patients where it will be contraindicated, where you don't want to dislodge the ligated vein. Okay, so that is the evidence for Ryle's tubes. Okay, then just a quick word about management of variceal bleeds. How different is it going to be? Like, what are the drugs indicated? He was telling you.
Vasoactive agents have to be used, terlipressin or octreotide.
Okay. So classically we use octreotide. What is the dose?
Initially bolus will give us 100 microgram bolus followed by 50 microgram per hour infusion.
Okay.
And then we have to again
okay. If at all you are
80 mg.
Yeah. If you are replacing octreotide with terlipressin, what is the dose? Terlipressin usual dose is 2 mg q 4th hourly. Okay. And once the bleeding is subsided, you can convert to 1. Okay, fine. So that is with variceal bleeding also. Variceal bleeding, again endoscopy, you have further specific kind of treatment will go. Ulcers, you told about thermocoagulation, hemoclips. Is there anything else other than this? Adrenal, local adrenaline. Okay, that's one thing which people commonly do. Along with that, you add thermosclero or hemoclips and all. Okay, fine. So now, suppose in a situation where you are not able to control the bleeding with endoscopy, what will be the next step? It's not that all patients will be able to control. You find that it's an ulcer, ongoing ulcer bleed. It's a significant arterial loose. Whatever endoscopic interventions you are doing is, the patient is continuing to bleed. What will be the approach in such kind of a scenario?
We have to start antifibrinolytics. Balloon tamponade.
Okay, so there are two things. One thing is what is usually practiced at bedside. What is sense taken plug and mortar tube?
There B2.
So basically that is one thing which can be done on a bedside on an emergency life-saving method. So basically it has two balloons, right? It has one that is a decontamination port, and the other will be an esophageal port and a gastric balloon. So you have two balloons. So you insert it, one end of the, and three ports are there at the end. So one port will open up to the stomach, which you can aspirate, and second will be a balloon which can be dilated in the stomach. So you dilate that and you pull it up. Now you have the balloon stuck at the abdomen, right? Then you inflate the second balloon, that is at the length of the esophagus. Okay, so there is a modification to your sense taken plug and mortar tube that is called as a Minnesota tube. So the Minnesota tube comes with one more port. Okay, the extra port at the Minnesota tube is at the esophageal end. So if there is any blood above the bulb, that can also be aspirated. Remaining everything remains same. Okay, so that is one thing which definitely we can do it in ER itself, where we are not able to control the bleeding, whatever be the etiology. In those kind of situations, probably this can have a role. But as said, this is more like a life-saving emergency kind of procedure. It's not a definitive management. Okay, what will be the next step then again? That will be again radio interventional kind of procedures. So definitely you can go for an angiogram, see whether there is any definitive vessel is identifiable, which can be embolized. Selective arterial embolization will be one thing which probably will have some role. Okay. Even if that is also not working, then you go for the definitive surgery kind of measures. Okay, that will be the escalation pathway. Okay. Anything else, Sebin? Did we miss anything? Nothing. Okay, fine. Thank you.